Nana Kofi-Koakye, who is a research fellow, a public health professor, has joined us on Zoom, and we're going to be having a conversation with him. Nana Kofi, good morning.
Good morning, David. Thank you for having me.
Yes, Nana, it's been a while actually. Happy New Year to you, first of all.
Happy New Year to you too, and to everybody watching.
All right. Now, what have your observations, generally speaking, as we get into this conversation, your observations from, let's say, 6 months ago, or just basically from the beginning of the COVID period? You came into Ghana and you've been here. You've seen what we've done. COVID March last year to, let's say, this time. What have your general observations been?
Well, like it's often said, right at the beginning of the outbreak, Ghana had the benefit of seeing what other countries were doing as emergency measures, especially in the form of lockdowns. We detected our first cases when the lockdowns in Asia were just ending, but also when the lockdowns in Europe were really ramping up and getting to a more serious level. And a lot of that and the early signs informed what the strategy we took up, which was to attempt to slow down the rate of transmission through policies like distancing in truckers initially, then suspension of large gatherings, and then eventually the lockdown itself. Unfortunately, I think since the lockdown ended, it's been quite clear that public behavior has increasingly gotten reckless, compliance has gotten increasingly low, and enforcement has gotten low as well. But when it comes to the question of, and if you look at our data, we're in a situation where, Ghanaian scientists told us a few months ago that in a seroprevalence study, which is to say an attempt to estimate how many people in Accra and its environs had previously been infected with COVID-19, the number that they came up with was about 1.2 million, which represented about 20% of people who were sampled.
Wow.
That's extremely high when you put it in context of global numbers. Right now, the leading positivity rates in the world are in the region of 40-30%. So having a 20% is actually, it's pretty serious, especially when you have a scenario where the WHO expects that you will have nothing above 5% if you are doing the kind of easing we're seeing here. Importantly, I think looking at public compliance as a variable in the policy response, there seems to have been a serious disconnect there. It doesn't appear as though we've all seen the fact that people are not wearing masks and have been wearing masks less. That doesn't appear to have been translating into the actual response we're doing. We know, for example, that during the holiday season, bars and clubs, for a fact, were open. That obviously was not translating into a policy perspective. And we know also that there are high-risk situations that we've been getting involved in through the campaign period. It's not consistent with science to say that political rallies would not be a risk factor for spreading COVID-19. It's not just a question. It wasn't just a question of the people being like in large gatherings outside. They get there by sharing crowded buses. They go and eat at breaks in big groups. Those are the kind of things that actually we're concerned about. Not just 3,000 people standing outside in a big crowd. And it was important that we actually reflected that in the policy. So there's been a bit of a disconnect there. But I think when it also comes down to a question of personal responsibility, there's a real challenge with people's appreciation of the risk. It's quite clear that there's still a lot of people in Ghana who don't take COVID-19 seriously. It's very clear that there's a lot of people in Ghana who don't think if you get it, it's that serious. And too much of the time we talk about it like it's a binary thing between live or die, when we know that there are lots of people, even young people in Ghana who publicly, in the media and stuff, who publicly talk about the fact that they had no pre-existing conditions, they got an infection, and even after viral recovery, they're still struggling with it. So we're trending in the wrong direction. All the numbers would suggest that we're not even testing enough to know where exactly we are. And public behavior, public compliance, public risk perception also not where it needs to be. So we need to turn this thing around quickly, because the reality is that the worst case scenario for Ghana would be one where, given the lackadaisical approach in policy and public compliance, for us to have or import a strain like the UK strain or the South Africa strain, one that either spreads very quickly in the case of the UK, or one that, in the case of South Africa, appears to have more serious consequences for younger people. So we really need to be operating as though that has already happened and be responding in our public life in that sense. We have to go back to the hand washing. We have to go down to cutting down on staff levels in offices. We have to go down to spacing in public transport. That's the science of it, because we know that if we don't do those things, the outcomes are predictable. And everything we've seen in the campaign season, in the holiday season, it's not surprising that we're hearing the anecdote of hospitals being full. We're seeing the Ghana Health Service report the highest level of severe and critical cases at any point in this pandemic. And we're obviously seeing that in context of that we're not still testing enough to get a clear sense of actually how large the situation is. So we really do need to turn things around quite quickly here.
Yeah. Now, speaking of testing, I know that one of the protocols that was essentially used to drive down or limit the numbers at the very beginning was this protocol of contact tracing and testing. Very, very aggressively we were doing at the beginning. Now, I'm hearing lots of different situations where people are saying that nobody is asking them about their contacts. Nobody's asking them about, who they came in touch with and so on and so forth. It seems to me, and I'm not sure if it's you're getting the same sense of it, that contact tracing has been thrown out of the window.
Unfortunately, my own anecdotal experience would suggest that for sure we're not doing contact tracing at the levels we're doing in March or April. I get almost every day on Twitter in my DMs questions about what people should do if they have an infection. I'm not a doctor, but their question is always more about how do I make sure that people have contact, who's going to do the contact tracing there. And I can count dozens of examples of people who, especially who tested up private labs because they were told by a friend that they were infected, they found out they're infected, and all this chain of people who end up getting tested is because of a friend telling a friend that I'm sick and you might have been exposed, so please go and get tested. But it doesn't. It's very difficult to tell whether or not the private sector lab tests that are being done are translating into contact tracing efforts. I know that at some of the public labs all around the country, Takadivet, Noguchi, there is some effort to follow up contacts after they're diagnosed, but it's obvious that we are not, that free public testing is not the majority of testing we're doing. A lot of people are paying for private testing, and if we're not doing contact tracing there, when already we reduced testing by almost 75% from July and August, and we're only tracing a small share of that, it's very obvious that if you cannot actually say logically that that contact tracing effort is going to be effective at the level it needs to be.
Okay.
And we know that because of the rates of transmission, the window is also very small. If you can't trace a contact in 72, 96 hours, that opportunity is gone really to prevent onward transmission. And so if we know all those things, we are tracing very few, we're not tracing most of them in time, it's magical thinking to assume that there will be no consequence in terms of further infection.
All right. Now, Apioko is co-hosting with me today, and I'm sure she has a few questions for you herself.
Yes, absolutely. Good morning. Good to see you, and Happy New Year, Nana Kofi.
Good morning, Apioko. Happy New Year.
Good. So my question has to do with the possibility that we may be seeing a new strain of the virus in Ghana. I mean, the president's last COVID update, which was just a little over a week or so ago.
Yeah.
Right? He mentioned that our health professionals here haven't seen any new strains. But I'm hearing symptoms that sound new, and I'm wondering if, from where you sit, you suspect that we may be seeing new strains. And let's not forget that we're just coming out of the holiday period. We're almost halfway through January, and we had people visiting the country. Indeed, some people moving back here during the months of November and December and early January as well. So are you seeing anything that indicates that we may be looking at a new strain of the virus?
Well, first, I don't want to speculate, so I'll start with the fact that the only way we'll know that empirically is by the kind of work that Dr. Yabediako, Dr. Kojokwashi, Dr. Wandari are doing at WACLIP, where they are doing genomic surveillance. And I know that they have really been up and doing in that respect. So to get the answer empirically, I think we'll wait for them to do their work. But if we're looking at the fact that we're seeing quite obviously that there seems to be an upsurge in severe and critical cases at our hospitals. Like I said, on January 7th, we reported a record number of severe and critical cases. Now, the question is, why would that be happening? It could either be happening because, one, we have the disease has gotten more transmissible, so we have a lot more people getting sick. But even if it's only a small number that are actually in need of severe and critical care, a small percentage in need of critical care, that number is actually kind of big, if that makes sense. The second scenario is one where it's a question of severity, as we might see in the South Africa strain, where what the scientists are reporting is that they were seeing a larger representation of young people with no comorbidities coming in with severe and critical illness than they were before the strain mutated into what it is now. So that could be a possibility as well. And even in the first scenario where it's about greater transmission, that would also be kind of consistent with both the UK and South Africa strains. Third scenario is that maybe, and it's hard to tell because Ghana Health Service is providing the kind of demographic detail on people who are getting infected now. Maybe it's because through the holiday season, people are infecting older relatives, and so they are coming up with more severe illness, and that's why we're picking up on those different symptoms, because perhaps we have not been seeing high levels of infections among people over 65 so far. But all these three are speculation that can be empirically confirmed when WACLIP comes down and does their study. But it's quite clear that at least one of those things is happening. And if it's a case where older, more people are now getting infected, then it's obvious that our infection control and vulnerable population prevention measures have not worked. If it's a case that we have a more severe strain that's coming up, creating more severe outcomes, then that's also a question of whether or not our genomic and disease surveillance, has been effective. WACLIP has been carrying that bucket with Noguchi pretty much solo so far. And if you look at if it's a case of greater transmissions, then it could either be because we have a more transmissible strain, or because activities that went on in the holiday season and political season are paying off. All of those things, no matter what the scenario would be, would suggest that we have a policy problem, but at least some of those could be correlated with what you'd expect to see if we had the South Africa or UK strain. And it's important to be clear that our airport testing regimen has holes in it. If you are doing just the math of what the manufacturer of that test says, the number of cases we found at Kotuka so far, on average, you'd expect that for the about 850 cases we detected so far there, that's people who have tested negative PCR before they arrived and tested positive on antigen test here. That antigen test would still miss about 12% of those people. And if we don't have any quarantine measures, as we do not, you can expect that if those people get through the system, they're going to holiday season Accra, they're coming to political season. It would not be outlandish to expect that those strains might be here already. And importantly, those strains also, they were detected in the UK and detected in South Africa. That doesn't necessarily mean that that's where they began. Mm-hmm. So basing the strategy of the idea that because it's in UK and it's detected at some time, it hasn't yet reached here, or it wasn't here before the UK figured it out, that's again not consistent with reality. So we like I said earlier, we have to behave like this new strain is here, because if it is here and we are doing what we are doing right now, there's going to be some pretty severe consequences, regardless of whether it's the UK or South African strain.
Great, and I'm happy that we moved into the conversation about testing because there's something that we've observed, both David and myself. When you go and get a test done at a private facility, you get a phone call regardless of whether your results are positive or negative. But when you go to our public facilities where the testing is free and a lot more people are going to these facilities because of that option, when you're negative, you don't get a phone call. Now, I get it that you may have to pay more attention to the positives because that requires some kind of, it's more urgent, right? So it requires some urgency in reaching people who are positive. But then this is also a disease that's affecting people not just physically, but psychologically as well. And I'd like to think that if somebody has tested, just knowing that they get a phone call or some kind of communication that says, you know what, your test came out negative, that will allay fears and sort of calm them down mentally. So what's happening there? Do you know anything about that?
I'm not sure exactly what's happening with those lack of follow-ups for negative cases, but like you said, especially people's perception about COVID-19 risk kind of also ebbs and flows with public, discourse about it. And it's quite clear that, again, it's a matter of focus in Ghana. And for people who are waiting for positive results, for test results in that kind of scenario, it is really mentally fatiguing to be sitting around not knowing what's coming, not knowing where you stand. And I think it would be best practice to really make sure that everybody's getting at least a follow-up to know where they stand and know what their status is. I think that's something we have to try and aspire to because, like you said, it's great mental stress, great psychological stress especially if you think you might, there's also like seasonal flu that's popping around. So if you think you have one of those things and you're not getting back, I could see how it's stressful. But importantly also, if we allow a scenario where that becomes the public understanding that you might not always get a call back, especially when we know that some of the public labs delay quite a bit in providing results. If somebody thinks, okay, 2-3 days, I haven't heard anything, so I'm all good. When we know that, earlier in the year when the labs were really suffering, sometimes the testing delays were 2 weeks, 10 days. That's not a scenario where you want people just deciding that I haven't heard back, so automatically I must be good. Especially if you're not telling them what kind of delays to expect.
Yeah.
So those are the kind of things that we have to start getting right. But it's also worth remembering that public health and healthcare sectors are really, really understaffed and under-resourced. So they're going to have some practical constraints. But it's also been 300 plus days of COVID-19 in Ghana. And there are some things that we should actually be able to expect improvement on. It should not be the case that, our policy response is only kind of tighter to when there's public attention, not what the science actually says, and not what the actual reality is.
Right.
All right. Thank you so much for spending your morning with us like this and for helping us to understand where it is that we find ourselves now. Nana Kofi Kwache has been speaking to us, and he's an assistant professor in public health in New York. So, yeah, Appy, the situation is dire.
Yes, it is.
And I think the earlier the Ghana Health Service ramped up, its protocols, ramped up awareness, ramped up, that whole series of things that we did.
Yes, at the
beginning, the better it will be,
Absolutely.
for all of us. But we do have a packed show for you.